Welcome back to the Clinical Leadership Podcast. My name is Dr. Alex Earl. I'm a chiropractor, and this episode we are excited to have Dr. Joe Tatta. Joe Tatta is a physical therapist out in New York City. Is that correct, Joe?
That's right.
Fantastic. Well, Joe runs the Healing Pain podcast, and he's got a few hundred episodes already in the bank. So if you're really interested and you like what you hear from Joe, I highly recommend you go over to wherever you listen to your podcasts and you download as many as you can and listen to him. He's had some very, very well respected individuals from all over the world on his show. So this is a shameless plug for your podcast. But Joe, I just want to thank you for carving out some time and joining me today. For our viewers and I should say for our listeners, could you just tell us a little bit about yourself and we'll go from there?
Sure. Thanks for having me on, Alex. It's great to chat with you today. So the short version is I'm a physical therapist. I've been practicing since about 1995. I've worked in lots of different practice settings, both what we call inpatient settings very, very early in my career for a couple of years. But the most of my career, about 25 years of it, has been spent in outpatient orthopedic, sports medicine, chronic pain, specifically with a focus on lifestyle medicine and building out lifestyle practices for people.
Fantastic. That's why I wanted to have you on today. You've got a really interesting perspective from the trenches. And I really, I subscribe to your newsletter. I get your emails. They're very personalized, a huge hat tip to how you communicate your message. Could you share with us a little bit of the process of your journey going from, from the manual therapy side into the limitations of manual therapy and now where you've ultimately found a home, so to speak, with what is called ACT or acceptance and commitment therapy?
Sure. Early in my career, probably about in year two of practice, I actually worked in a practice in New York City. And it was a sports and orthopedic practice, but it had a focus on what we call performing arts medicine. So we treated Broadway dancers, ballet dancers, performing artists. That was about 60% of my caseload. Extremely healthy population, extremely young population. These are patients that want to exercise. They want to listen to anything you have to say about health and wellness. And at that point in time, the practice I worked in was heavily rooted in a kind of a manual therapy and exercise approach. And it works really well for, a good, I would say for dancers specifically, probably a good 75% of them. Like that's pretty much all you need, so to speak. However, as we know, human beings and injuries and diseases can be complex. So it became really apparent to me early on that just manual therapy and therapeutic exercise was not going to take everyone as far as they wanted to go or serve me as the practitioner with taking them as far as I would like to see them go in their rehabilitation. So that's really the kind of the first place where I was like, oh, interesting. I have these really healthy people who have injuries. Most of them are acute injuries. Some of them are chronic in nature, but there's something more that I need with regard to helping them rehabilitate other than just manual therapy and exercise.
And gosh, I have so many questions to follow up on that. I'm gonna try to narrow it down, but were you working for a company at that point or were you in like a private practice setting on your own? So I guess the reason for my question there is who did you have to convince that you wanted to keep going, or is it just yourself?
So at this time, I worked for another physical therapist who owned a private practice.
Okay.
He actually owned a couple of practices in New York City that focused on performing arts medicine. And it was, PT owned clinic. There were probably about 10 of us total between two clinics that we, shared the responsibility for patients. Interestingly enough, these clinics also had a Pilates studio attached to them. So at that time in the late 90s, the Pilates method of body conditioning, or what's known as the Pilates method of rehabilitation, was it was really popular with dancers and actors,
Right.
but it was just starting to trickle into kind of the mainstream where, the average Joe, so to speak, would look to go to Pilates for ways to keep themselves healthy. What's interesting about Pilates is there's definitely a mind body aspect of it.
For sure.
So when my patients were coming to the end of their course of rehabilitation, specifically spine patients, because we had a lot of patients who had spine injuries, and Pilates is really great for the spine and for spinal health. So when they were coming to the end of their physical therapy course of treatment, I said, "Hey, before you go back to the stage, which is rigorous because they're doing 8 shows a week, multiple hours of activity, so to speak." I said, "Why don't you try some Pilates?" Basically, I was using it as a way not only to condition them, but also to test them to see if they can do something that was almost sport specific or performance specific in a way that was healthy for them. And what I found was, of course, there were physical aspects of it, the physical training aspects of it, which are beneficial. But Pilates also had a mind body aspect of it that I noticed people really took to and started to help people with um, things like stress and de-stress around the experience of their pain specifically. So I didn't have to convince the group I was working with necessarily that there's something more here. Although at that time in 1999, 2000, the idea of the mind influencing the body it wasn't new, but it definitely was not ingrained in our culture the way it is now. Most of us who are, progressive practitioners on some level, whether you're a chiropractor or a physician or a PT, realize that, hey, there's more going on here than just the physical body. I had to, it's interesting because in that practice, there were performing artists, but about 25% was the average person off the street. Just your typical what we might identify as wear and tear injuries, things like that, that came in for treatment. And with those patients, sometimes I had to convince them that, hey, there's more going on here than just the actual physical injury. So there's more going on than just the joint. There's a mind or a brain attached to this that is informing um, not only how you feel, but your long-term outcome.
Right. I think there's so many clinicians that get into this channel of, okay, everything that enters in here is physical, and that's very common in biomedical oriented practices, and really the biopsychosocial model, which we'll get into in a second here. It does include, like, we have to say, it does include the biological. We can't forget that is a major component of it. But can you share a little bit of your um, we'll unpack this a little bit more, but could you share a little bit of your journey into how you have changed the way that you communicate with patients? Because I know inside of 5 years, I graduated 5 years ago from chiropractic school, and I don't talk to patients now the way that, and I almost have to laugh at how I talked to patients when I first came out. Could you share a little bit about how you've had to learn and sharpen your communication skills with your chronic pain patients?
Sure. I mean, the key point I think with people with chronic pain is actually I do less talking than I used to. I do a lot more listening. So that entails first giving people space to talk. So just creating a safe context for them and literally creating a safe environment for them where they feel comfortable with you to share and tell their story about what they've been through. And through the sharing and telling of that story, there's a validation process that happens for them because oftentimes no one has validated their experience, and they've seen multiple practitioners who after a while they figure out that this person doesn't really know what's wrong with me. They're confused by my presentation, and in essence they lose confidence with that. So the first piece is a safe environment for people, really important with regard to chronic pain, because oftentimes many of our patients with chronic pain have adverse childhood experiences, which involve early life or midlife trauma, which impacts many pain mechanisms that we talk about and that we see. So just giving them that safe environment where they can talk, they can tell their story, and then you as the practitioner listening. And in school, we're trained so much like to ask questions, and it's really important to ask questions. And most of those questions should be open-ended questions. But after you ask that open-ended question, giving them what I kind of call the runway, where they can kind of take off with that story and begin to tell it. And sometimes it's interesting, Alex, sometimes that involves a little bit of uncomfortable silence. And that uncomfortable silence is just giving that person a minute to process and say, oh, there's actually someone here who wants to learn about me, wants to learn about my life, wants to learn about my pain. And they take people a couple of minutes, sometimes even a couple of sessions to warm up to you and to really, solidify that therapeutic bond or that experience that they're having for them to tell their entire story. So, giving them space first, asking open-ended questions. The second one is really super important. And then the third part, I already kind of mentioned this in our chat here, is not just asking people questions about things that are of a clinical nature, like where's your pain, what's the intensity, when is it better, when is it worse, how does it present, what do your tests look like, but actually asking them about their life and asking them about the people that are important to them and the activities that are important to them and the things they've been missing out on. So when you ask them questions like that, that's a really different approach to their pain and to their care than they've experienced with other clinicians for the most part.
I should say the communication skills absolutely has changed in my 5 years because I now listen intensely. Whereas previously I wanted people to know, like I'm smart. Maybe it was an insecurity that I had where I just kept talking to go, well, this is a disc injury. This is, this is this technique. This is why this is important. And now I'm just like, nope, I'll just ask more questions that provoke a lengthy response and shut up, very frequently, I'll share this with you real quick, then we'll move on. We frequently have chiropractic interns here. And I preface, before we go into a new patient eval, I'm going to say to the intern, I'm going to ask them what I refer to as loaded questions. Don't speak. And we'll talk about it later, but don't say anything. And sure enough, we go into the exam room. This just happened this past week. And I asked this person who came in with a knee-related volleyball, high school volleyball player, 6'5" at the age of 16, almost 17. And I said, so why do you play volleyball? And maybe about 15 seconds of silence. And I was cool with it, completely cool with it, because we know this is human behavior. He wasn't expecting to be asked that question in that moment. He was thinking, this is a chiropractor. He's gonna treat me with X, Y, or Z. We're gonna do fancy, treatment modalities where he's gonna adjust me, and then so he's almost caught off guard by my question of why do you play the sport that you love, volleyball? Why do you play it? And he went quiet, like I said, for 15 seconds, and then started talking about how he feel he went on a very spiritual, if you will. He went down a very emotional and societal, like his friends play, there's like value in the people that he plays with, and it was really profound. And we had a nice chat thereafter, kind of let the guard down, and we were able to then unpack what's going on here. But anyways, later, a few hours later, when we had a break from patients, the intern came back and said, so why didn't you say anything when you asked the question? And there was silence. Wasn't that awkward? And I was like, no. When you ask a loaded question to a human being and they don't say anything back, it's because they're thinking. They weren't processing that, or they weren't expecting a question like that. And when you ask a loaded question and there's silence, they're thinking of an answer. So don't speak. You're going to interrupt the flow. And that's absolutely something that I've had to learn and be comfortable with, is silence, really. Um, and a lot of that I've learned from people that have written incredible papers, have incredible courses and written books. And a lot of those people that I've read and followed and watched videos of, you've had the pleasure of interviewing on your own podcast. So guys like Derek Griffin, you've also had JP Canero, and you've had Peter O'Sullivan. And I was just listening to another one where you had Mary Grant, I think her last name, Mary Grant, where she was talking about cognitive functional therapy and ACT, and just brilliant clinical insights from your guests. So I want to unpack your podcast a little bit to say, you have some influential people on there. What are some interesting things that you've learned by running your own podcast?
Well, as you know, Alex, when you run a podcast, you're talking to someone for 30 to 60 minutes, so to speak. Um, so one, it's fun. So you get to connect with people like yourself that are doing awesome things in healthcare that we need more of. And through those conversations, there's an exchange of learning that happens, right? So you're learning something right now, and I'm learning something as well. So it's, in a lot of ways, it's away from a traditional model of like continuing education, where people go to a course, they sit down, they learn, and that's important too. But listening to two people converse in many ways is almost better than just listening to one person teach you, because you have two minds there. So it's been interesting for me. When I first started my podcast, I released a book in 2016. And the year before that, 2015, when I was writing it, the publisher was like, hey, you have like a website up and you have a blog, but you don't really have anything else around content. He's like, what do you think about, this is the editor at the book company, the publishing company. What do you think about doing a podcast? So podcasts really weren't that popular back then. And I said, okay. I said, I'll start one. I said, but there are some podcasts out there around things. He said, yeah, but I'm doing some research, and some of the things you're talking about, there are not too many podcasts out there. So I said, okay. I said, but I've done research. I still engage in some research, but I'm not a pure research. I'm a clinician knowledge translator. But I looked at the podcast as really a public service announcement for people living with pain and for the professionals that treat them. And when I started to look at it as a public service announcement, it kind of changed the way I frame the entire podcast. And with that, people have, really taken to it, because people are familiar with public service announcements, right? So we've heard them about smoking, right? Those actually have been effective and have, you're probably a little bit younger than I am, Alex, but I remember a time when pretty much you could walk into any restaurant or any bar and people were smoking cigarettes. And in most states and jurisdictions, that's now illegal. You have to kind of go outside to have your cigarette. But some of those public health, campaigns worked. Some of those around like physical activity and nutrition, obesity related. Some of those have been effective as well. Some of them have not been effective. So it's interesting because we know that information is useful for both practitioners and people with pain. We know that information can be beneficial. People can take it and they can use it to, self-treat, so to speak, or improve their self-efficacy. But I always try to reflect back on behavior change in my episodes, because ultimately what we're trying to do is change behavior. So I look at them as kind of these little moments, if you will. So even though the podcast may be 30 to 60 minutes, what are the little teachable moments in there that are effective for behavior change?
Perfect. I love that phrase, behavioral change, because that's in essence what we're trying to facilitate in our office. And we don't have 100% record of it, but we've absolutely been intentional with trying to modify and enhance someone's quality of life by just addressing this simple, lowest. Another physical therapist that we've had on, Chris Johnson, he's a PT. Now he's out in the Pacific Northwest, and he's like, just go after the lowest hanging fruit. And for a lot of times, that's simple lifestyle modifications that ultimately then have a dramatic effect on behavior. So it's really interesting. When I first started off in clinical practice, I want to fix everyone's movement function dysfunction. I wanted to, make sure everyone had, lower cross syndrome taken care of. I wanted all these like traditional manual therapy driven techniques. I wanted to rid the world of asymmetries. And now I don't care about any of that nonsense. I care about facilitating change.
Mm-hmm. And some of the things you mentioned are part of that change, right?
Yes, yes.
So, if a muscle is severely tight and it's affecting your motion, then that's a part of the change, but it's not the only aspect of change that we need in musculoskeletal care, so to speak. And it's interesting, Alex, as and you're probably observing this as you do your podcast, is when people are first kind of turned on to a biopsychosocial model, it's almost like there's a rapid kind of running, if you will, over to the psychosocial aspect, right? And that's almost like almost become like a psychologist. And I'm like, no, 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 don't do that. Like, don't lose all your other skills, because they're really important. And actually, if you look at just a purely psychological approach to pain, the outcomes are minimal. So it's not just the psychology and it's not just the biology or the biomechanics, it's all of it put together. And there's a lot of clinical reasoning that has to happen when you're putting all of it together. And it can be really confusing for people. So, hey, like, how do I take off my chiropractic hat and put on my counselor's hat, so to speak? And it's like, well, you don't. You actually have both those hats on at all times. And as you start to practice that way, you get better at it. It's just a skill that you'll learn over time, just like it took you 3 years to cultivate the skills you have in chiropractic care. It may take you that long to actually really cultivate a biopsychosocial approach to the treatment of pain and other chronic conditions.
Well, I should say that we also do educational events. So we've had a ton of opportunities, maybe I'll put it that way, to connect with healthcare providers and professionals that teach this way of thinking. And so I've had a front row seat since 2014 on this like trend of the biopsychosocial model and just kind of sharpening the saw, so to speak, and continuing to learn. If there's one thing that we look at, we are constantly, and when I say we, I mean everyone that's a part of the podcast and also in our clinical practice here, my team, so to speak. We're constant learners and we surround ourselves with lifelong learners. So what's cool is, yes, you've written a book, you have a killer podcast, you've got a good social media following. But what I'm really interested in, and maybe this is a good place to end on, and I don't care if it's an endorsement, I'm not bothered by it. Um, could you share a little bit about your ACT course that you've got? Who's it for?
Sure.
What are the benefits of it, and how can they learn more?
Sure. So ACT is a cognitive behavioral therapy. It stands for acceptance and commitment therapy. It's what they call a third wave cognitive behavioral therapy. So the first wave of cognitive behavioral therapy is focused on identifying problematic or maladaptive thoughts and then changing them. So in essence, focusing on symptom reduction. And there's good research that there's some cognitive behavioral interventions that are minimally effective for reducing symptoms that are related to maladaptive thinking. Um, from that family of therapies has grown pain neuroscience education, which I'm sure you have covered, or you probably will cover on your podcast. That's really a form of cognitive behavioral therapy where you're looking at maladaptive thoughts and beliefs and helping change those so people can function better. There's a whole nother line of research, a huge body of research actually, that shows that for some people, and quite often a lot of people who struggle with pain and chronic health conditions, that thoughts and beliefs about pain don't change so readily. And if we actually try to change someone's thoughts and beliefs, we can actually cause them more harm than good. Because what happens is we wind up in a struggle with their thoughts and beliefs, and they're struggling with them as well. So it just becomes kind of this like, messy place to be with people. So instead of changing thoughts and beliefs, we help people relate differently to their thoughts and beliefs. And that's where the third wave acceptance and mindfulness based interventions have started to rise to the top because we realize, hey, if someone's had fibromyalgia for 2 decades and they've seen all sorts of different practitioners who've told them all sorts of things about pain that are not true or maybe only partially true, it has an impact on their thinking. And we're probably not going to change a decade or two's worth of prior practitioners' thoughts and beliefs that have been inserted in their mind. But let's see if we can help people adapt in ways that are healthy, even if they're having those problematic thoughts and beliefs. So that's where acceptance and commitment therapy comes in. And then the other thing, Alex, is also a whole nother range of conditions that even the best pain medicine that we have in all of our professions, we don't have a really good way to quote unquote turn off pain. So if we can't turn off pain, how can we help people function as best as possible, even if they have some pain still present? And ACT is really, a cognitive behavioral therapy that has shown the best evidence for helping people cope on that level.
Fantastic. I'm really interested and excited to learn more. Like I said, I'm a lifelong learner, and I've said this maybe on every podcast that we've recorded as well. But I started this off like purely selfishly to interview people like you to learn, in a front row seat, what expertise and knowledge that I can gather from you. And so, yeah, we are going to highly recommend your course. I'm also going to take it in the coming weeks here. And where can our listeners learn more about your class?
So they can learn everything about me on my website. The website is called the Integrative Pain Science Institute. So that's integrativepainscienceinstitute.com. And all the courses we have are up there on the website.
Fantastic. Couple of closing questions I'd like to ask as well. What's something, whether it's in regards to your podcast or just clinical practice career, what's something that you would be open and willing to share with us that's just a blatant mistake that you've made that you want some of our listeners to learn from?
A blatant mistake, Alex. That's good. Um, What do I think about that? I don't know if I have a blatant mistake. That almost sounds like it's intentional.
Yeah,
Um,
maybe I'll amend it to, yeah, let's just go with mistake. Yeah, let's just go with that. I like this. See, we're deciphering through a sentence. I don't like how I structured that either. So I apologize for the way that I said blatant. You're right. That made it sound like it was premeditated. But let's just say a mistake that looking back on it, you realized, maybe I should have chose option B, C, or D, if that makes sense.
yeah, some of the courses I've created, there are areas of it that I should have um, made a little bit easier for people to digest, because I've studied some of these concepts for years. So sometimes I forget, like, okay, not only have I studied this, but I've used it in practice. Sometimes, like, for example, nutrition, chiropractors get more information on nutrition than PTs get in school. PTs get just a little bit. So when they come to my nutrition course, for example, they're a little bit weary of, like, what is this? Like, am I going to crash some of the blood sugar? Like, do I have to put someone on a ketogenic diet? So for some practitioners, just kind of easing them into the process a little bit more, and realizing that their readiness to change can sometimes be a little bit slow, just like our patients' readiness to change can be. So just thinking about the people I serve, the practitioners I serve, the people to take my courses are primarily PTs, but I have a lot of um, physicians, chiropractors, nurses, and OTs that take my courses as well.
Fantastic. If you could give us a couple of books that you think our listeners should read, whether on Audible, listening to on the way to and from work, or what have you, that if you were to buy 10 of them and give them away as gifts, like what would that 1 to 3 books? What would those be?
You want 3 books?
Up to three, or you could go more. I don't care. Yeah,
Well, I'm going to plug my own book right now, Alex. So,
go for it. Go
um,
for it.
my latest book, which is called Radical Relief, that's a guide for overcoming chronic pain. It's based on mindfulness and acceptance and commitment therapy. That's
Is
a
that
really
for,
good one.
yeah? Is that for the public, or is that for practitioners, or both?
So it's both. I actually, inside the book, I give people a guide if there's someone overcoming chronic pain, and I also give a guide for the practitioners in there.
Brilliant.
So there's a little bit of both in there for everyone. What's nice about it is that it's a short book. It's only about 100 pages. So it's really good to use as like a clinical tool with your patients.
Nice.
After that, I would say read any book you can on motivational interviewing. Motivational interviewing really is a baseline skill that every practitioner should have, and it informs every other cognitive behavioral intervention that's out there, and probably is just as good as any other cognitive behavioral intervention that's out there. There are lots of different books on MI or motivational interviewing. And the third, let me give you a good third one. Um, any book you can pick up on behavior change, I would say is going to be really effective. There's two that are out there right now. Atomic Habits is one. That's a pretty good book. And the other one is just slipping my mind right now. Tiny Habits. Tiny Habits is the other one. I really love Tiny Habits. I recommend every practitioner check that out.
Will do. I've got a few Audible credits of my own, so I'll check out Tiny Habits.
So I gave you four there. It was my own book and three others.
Fantastic, fantastic. I appreciate that. Well, Joe, that's all I've got for you today. I can't thank you enough for coming on the Clinical Leadership Podcast here. We really appreciate all that you do, the guests that you have on, and the information and the content you put out there. Yeah, keep doing what you're doing. I mean, a lot of people see the product of what you're doing. They don't necessarily know the hard work that goes in behind the scenes. But I just want to say, commend you on all the hard work and books you're writing and courses you're working on. That the content you put out there is extremely valuable, not just to us as clinicians and practitioners, but also to the public. So keep doing the good work, my friend. Okay. And again, thank you for coming on today and joining me. Any closing remarks for us?
No closing remarks as well. I love what you're doing and keep up the good work.
Thanks, Joe. Appreciate it.